Right. So friends, good evening. This is again an opportunity to talk about orthopedic rheumatology. Till date, we had restricted ourselves to medical aspect, and this time we keep on operating on various joints for replacement and for other things also. We take this opportunity to discuss joint replacement in inflammatory arthritis, especially the technical aspects. I would love to request our very own president, Professor Ramesh Kumar Sen, to say a few words as part of his inaugural address. Professor Ramesh Sen, please.
Good evening, everybody. Thank you, Professor Jha. I mean, if we look at the progress in this year, I think this year Orthopedic Rheumatology Group has done an appropriate planning, execution, implementation. Everything has been very, very perfect. And I must congratulate you for your commitment for the cause. This actually, if you look at the subjects also, as we look in the general orthopedics also, as an orthopedic surgeon, we are both physicians, we are both surgeons. And the same thing has now been reflected into orthopedic rheumatology, as you were just talking about, that we had the medical part of it, and now we have the surgical part of it. And that completes the syllabi totally in this respect. And definitely, I really will lack words to appreciate the way you have taken it and you have gone through it. Kind of a syllabus, which I think Dr. Manish might have in his books also as a kind of a syllabus, when you cover from A, B, C, D and complete the topic. So that is what has been done. I really congratulate you and your team and the commitment and the help of Pannag, Bhushan to be there, and all the faculty members who have been continuously working. And I'm thankful to Dr. Lahkar also to have taken the things along now for the future also. All my best wishes for the future of orthopedic rheumatology. And for this year, I definitely have a lot of thanks to the group to have really done wonderfully well. And with that, over to you, sir.
Right. Thank you.
Thank you. Thank you, Dr. Ramesh.
Okay. So
Ramesh.
Pannag is already there. Yes.
Dr. Ramesh Sen.
Hanji, boliye, please.
Hanji, it is all due to you who has advised this time for a newer curriculum, surgery getting included, and I think I have fulfilled your dreams which you wanted to have.
That's right. That's exactly what I was imagining.
We had personal talk and you guided me, and we have taken the things to the conclusion.
Right.
And obviously, Dr. Jha had been the great master to guide us in everything.
Thank you, Pannag. Now is the turn of Dr. Navin Thakkar, our secretary. I think he has not been able to.
Yes, I could not contact him also. I tried to talk to him.
But he had promised he should be there. Dr. Chaddha, our president-elect, also is still busy. He has conveyed a message. Dr. Atul Srivastava, president-elect, also is busy otherwise in a family function. So now I officially request our very own president of Indian Orthopaedic Rheumatology Association, Dr. Shantanu Lahkar, for his welcome address. Shantanu, are you there? Shantanu was here. Okay.
Shantanu was here?
Shantanu? Okay, fine. Whenever he comes. So on his behalf, Dr. Manish, I think you should better say the welcome address. Indian Orthopaedic Rheumatology Association.
Yeah, good evening, everyone. So this is our very important webinar, which is filling the gaps of so many things in conclusion about the medical management and the surgical management, as we were discussing just now. So we hope that this is a starting point for a lot of the challenges which are being faced in orthopedic rheumatology, especially while we plan for a replacement arthroplasty, which may be shoulder, hip, knee, whatever it may be like. So we hope that this 1.5 hour, 2 hour academic feast would be very helpful to the young orthopedic surgeons who are very enthusiastically interested in arthroplasty as well as orthopedic rheumatology. Thank you so much.
Right. Dr. Chinmay Das, you are also the Secretary General of IORA. I would like to say a few words.
Yes, sir. Before me, I think we have Dr. Ram Chaddha has joined, sir. We can.
Oh, sure. Dr. Ram Chaddha, please. I'm so happy to see you here. Your few words as welcome address.
President of the IOA, Dr. Ramesh Sen, Professor Jha, senior dignitaries, it's a pleasure. I apologize. I was in the clinic, so please forgive me for my delay in entering today. It's indeed a pleasure. You are probably that subcommittee of the IOA, which has been doing extensive, regular academic work. And on behalf of the IOA, we really appreciate the effort that each one of you is putting in, because this is that aspect of orthopedic surgery which unfortunately or fortunately is overlooked. And it is that aspect which actually adds immense value to bone and joint diseases. And we welcome all the listeners and the attendees today. We have an excellent set of faculty which is going to share their experience and has been sharing over the past couple of months and is going to impart immense knowledge, which is an addition to the pure orthopedic surgery that we do. So thank you very much for inviting us here. It's a pleasure to be here. We have esteemed faculty, and please be most attentive because these are pearls of wisdom which are going to be shared. Thank you so much for inviting me.
Thank you. Thank you very much. I'm so delighted.
Thank you, sir.
Now is the turn of Dr. Chinmay. Yes.
Yes, sir. Good evening. Good evening, everyone. So this is the 7th webinar in a series of webinars by Indian Orthopaedic Rheumatology Association. And I think when you have got generals like our Ramesh Sen ji, Ram Chaddha ji, our very own SS Jha sir, and Manish, Khanna, so I think we can go to any war. And I just welcome you all to this webinar. Let's have a fruitful discussion. Thank you.
Thank you.
Sir, Lahkar sir is there. He can speak.
Lahkar, are you here?
Yes, sir. I have just linked up. I was having
please go ahead with your welcome address.
So on behalf of Indian Orthopaedic Rheumatology Association, today we are having a new concept and coming up with orthopedic rheumatology with surgical aspect also under the guidance of our Jha sir and Manish. And with this word, I welcome all of you so that we will have a more fruitful discussion. Thank you, sir. Thank you very much.
Thank you. Now is the turn of our very own convener, Dr. Pannag Bhushan, to welcome.
Good evening, friends. It has been really great honor to have all these things, the 7th webinar, and a very serially progressive webinar. The rheumatology subcommittee had been there for years, but the attitude and the approach had been different. This time, of course, under the guidance of Ramesh Sen and with the help of Navin and Dr. Chaddha, we have taken it to a new direction, and as said by all of you, a fruitful direction. I am really thankful to IORA also, the original President Emeritus and presently the advisor Manish, Khanna, Shantanu, Lahkar, our own Dr. SS Jha and Chinmay, who had really been helping us with the IORA team to conduct this IOA rheumatology seminars and webinars. Besides, I am thankful to all the speakers who have taken it to a new height. Everybody talks so much sense, so much science, and so much of stability that it has taken the rheumatology understanding to new heights. I again feel that it is time that orthopedic surgeons are basic at the helm of the affairs, because the moment the joint comes, our rheumatologist friends, no intention to them, no words to them, but they become helpless and we step in. Now we have also tried to understand the things, and this IORA group has really, really helped us. Thanks to Manish, thanks to Lahkar, thanks to Chinmay. Please start this conference. Thank you.
Right. So, friends, now is the time for introduction to the topic by none else but Dr. Manish Khanna. Manish, please.
Well, good evening once again. So as we were just discussing the inflammatory arthritis, the joint replacement, the technical aspect, definitely in next 1.5, 2 hours, you're going to have a wonderful time. But before that, my job is to say what is actually technical aspect. So everybody say that we are already doing arthroplasty. What new actually? What thing to be pondered upon? That is my aim in just 2-3 minutes of time. We all know that success of any arthroplasty procedure is dependent upon multitude of factors, which includes, of course, the overall health, the ability to adhere to the physical therapy, which is very important, and of course, the surgeon's skill. So that we all know very well. Now, these such patients with having an inflammatory arthritis, they actually have a systemic onset also of disease, like a patient of a rheumatoid, which we are going to operate, maybe having a lungs cardiac pulmonary fibrosis. So that is very important. Now you have after 1.5 years of, or rather many years of this workup with all the webinars since last years, everybody will be able to appreciate that methotrexate is a drug which is again a cytotoxic to the lung and cytotoxic to the lung at the same time, that systemic involvement of lung may be a feature which is very important. Now, this has to be taken care by orthopedic surgeon because he or she is going to, we can say she because now young orthopedic surgeon females are there. They're going to operate these patients. So the medication, if we are planning for a methotrexate, it has to be given, it has not to be given. What are the things? There are so many things all around which are very important to work it up. Similarly, if you're planning a shoulder arthroplasty, for example, so definitely before finalizing, for example, this patient 55-year-old with a severe damaged shoulder coming to you for a shoulder arthroplasty, we'll say, okay, fine, we'll go for a shoulder arthroplasty. But before commenting, yes, it has to be very important that you have to see whether the cervical spine has been involved or not, whether the disease is still in some active stage, because in that case, there would be some fibrosis, there will be some changes all around the atlantoaxial joint, and atlantoaxial subluxation may be a nightmare for an anesthetist as well as an orthopedic surgeon who is operating the joint. So there are so many things all around, which if can placed according to the place, it will be a wonderful, wonderful guidance to all orthopedic surgeons. Similarly, again, if you're planning a hip, if the patient with the hip, knee, and foot is coming there, of course, we have to work off for the foot most importantly, because unless and until the gait is improved, there's no use of going for a hip replacement actually. And for the knee and hip is again the same thing, because the referred pains are there from the hip to the knee. So even if you do operate a hip, operate a knee actually, and hip is not being taken care of, so again, it will be a difficult task. So these are small things which if we can follow, it would be wonderful. So arthroplasty, according to me, is not an arthroplasty, it is a workoplasty. For best result, a proper workup, and proper workup would only be there if you are medically and the surgically sound. That's all. Thank you so much. Over to the next speaker.
Thank you, Dr. Manish, for elucidating that in a case of rheumatology, it is not only the joints, but the other associated structures are also important, including the vital organs, even the heart. So now Dr. Pannag Bhushan speaks on how it is different from other joints. Dr. Pannag. Your slide is visible. Yes, Pannag, you are not audible.
Am I audible now, sir?
Yes, you are.
Sir, so arthroplasty in inflammatory arthritis, how it is different from our normal arthritis? If we see in the hip, knee, or ankle, there are changes: osteoporosis, avascular necrosis, contracture, deformity, bone loss, and if it is hip, it is protrusio acetabuli. All these are very big challenge. That's how it is different from the normal arthroplasty. So if we do it, failure is high. Today I talked to 8 arthroplasty surgeons across the India, and they said that if Bhushan rheumatoid होने से थोड़ा नहीं करना ही better रहता है. So failure is high even in the best hands. DMARDs, most of the patients are on DMARDs and they can continue. Rather, it has been seen that if the methotrexate is continued, the chances of infection are less. There had been many studies. Now, biologicals. TNF-alpha inhibitors are really depressing our immune system. Immunosuppression is there, so the infection is high. Therefore, TNF-alpha inhibitor have to be stopped. There has been a Swedish registry for that also. The Swedish registry has also confirmed it, and there had been another registry that has also confirmed it. So TNF-alpha must be inhibited. That's the difference. Usually, invariably, whenever we are doing arthroplasty today, we are going for uncemented for its longevity and strength of the implant bone interface. But no, if it is our inflammatory arthritis, we have to switch to the cemented. That's how this arthroplasty is different from the normal arthroplasty. And the uncemented, if done, there had been studies that its failure rates and the loosening are very much. The post-operative recovery, since the bone is osteoporotic, therefore it's prolonged. The patient walks very and chances of periprosthetic fractures are really, really very high. Now, the venous thromboembolism. Here there is a slight confusion. The studies have shown that in rheumatoid, the venous thromboembolism VTE is slightly lesser as compared to the normal. So it is a green signal. Risk is lesser in rheumatoid, but to the best, it's controversial. Now, if there is a revision, again, it's challenge because the failure rate is really, really high. If at all it has to be done, it has to be cemented again with pack of more cellularized graft. And the sequence, usually if it's lower limb, patient comes with hip, knee, and ankle. The usual sequence, what we do in our day-to-day practice is replace the knee first, but no. If it is an inflammatory arthritis, the hip has to be corrected, length has to be maintained, alignment has to be done, then the knee, and then the ankle. This is what I wanted to say, that it is different in our cases from the normal arthroplasty. So if we are touching a rheumatoid, we should go by the statement of all the 8 surgeons from 8 corners of India, with whom I have talked personally today, and they say that it is best avoided, and if not, then it is to be operated with great care. Obviously, all the things what I have told. Thank you very much.
Thank you, Dr. Pannag, for talking on very short notice about how it can be different from routine osteoarthritis. Well, in the meantime, I welcome Dr. N. Mukherjee, who is
Namaskar, sir.
here.
Namaskar. Thank you.
Namaskar. And now is the turn of the cream member of the team, Dr. Dhanasekara Raja from Coimbatore, who speaks on total knee replacement, the technical problems. Dr. Raja, please.
Thank you, Dr. Jha, respected chairman, senior faculty and colleagues. I'm going to talk about total knee replacement in rheumatoid arthritis, the technical consideration. So at the preface, I would like to talk about synovitis first, then arthritis. Arthritis in active disease is different from arthritis in advanced disease, which present with deformities. And deformities we see is fixed flexion, valgus, stiff knee, and combined hip and knee arthritis. Many patients present with synovitis with early arthritis. So they benefit from synovectomy, arthroscopic synovectomy, to reduce the load of the biological agents required to control the disease. But eventually they land up in arthritis and they require a total knee replacement. So arthritis, either it can be an active disease with the early arthritis or a burnt out rheumatoid arthritis. The problems with dealing with active disease, we already discussed. There is osteopenia, synovial hypertrophy, and joint laxity. Patients are on DMARDs and biologics, so the increased chance of wound infection and delayed wound healing. And if you are stopping biologics or DMARDs, there is acute flare-up of disease and there is multiple joint pain. Patients are not able to cope up. So you need to balance between the active disease and disease-modifying agents. So there is a paper on biologics and risk of infection. Though this conclusion is not very clear whether these biologics increase the risk of infection, at present we try to avoid the biologics perioperatively. We need to stop it 2 weeks, at least one half-life before the surgery, and restart after 6 weeks when the wound healing is completed. So problem with burnt out rheumatoid arthritis, we have fixed deformities. As we can see in the X-ray, there is concentric joint space reduction, osteopenia, and on top of it, there is stiffness, and there is risk of intraoperative fracture and ligament avulsion. So there is higher risk of tibial component loosening. We need to use extended stems and cemented extended stems. So one group of patients with juvenile rheumatoid arthritis who present very young, they have very small bony anatomy and they have fixed deformities. So dealing with these patients require specific small implants. Sometimes we need to have a custom-made implants. They have higher risk of complication, but the outcome is very good in these patients. So coming to your standard presentation of rheumatoid with secondary arthritis, this is a typical example of rheumatoid arthritis with tricompartment arthritic changes. Most of the time, the deformity is in either mild valgus or varus due to secondary arthritis. So we do a standard total knee replacement after good control of the disease and stopping the biological agents. A standard total knee replacement gives good relief. Whether you're using a cruciate retaining device or substituting device is an individual choice. Generally, I use cruciate substituting device because I'm not very happy about the status of the posterior cruciate ligament. And I always resurface the patella. So in patients with inflammatory arthritis, I tend to resurface the patella. So there are reports about using cruciate retaining processes with long-term good outcome. So this is a 20-year follow-up of 72 knees done by the Miller-Galante processes. 20-year survivorship is around 70%. The loosening due to instability is only survivorship out of instability is 93%. They're not increased instability. So usage of cruciate retaining process can also be done at an individual preference, but my preference is a substituting type of processes. The most common presentation is fixed flexion deformity, and many of the patients have stiff joints. So this is different from primary osteoarthritis. This is a case of typical primary arthritis. We can see hypertrophic arthritis. This is a dual plane deformity, combined varus and FFD. Here we do a complete post-operative release and correct the fixed flexion deformity. So this is different from osteoarthritis. In rheumatoid arthritis, is more of posterior capsular contraction, and most of the time we end up doing additional distal femoral effect. So this is an examination under anesthesia. Many times the fixed flexion deformity gets corrected under anesthesia. But if there is a residual deformity, we need to correct it during surgery. One option is to increase the distal femoral cut so that your extension gap is increased. So we do a provisional cut, do a proximal tibial and distal femoral cut, assess the extension gap. The gap is small. We go and release the posterior capsule. So we need to lift the femur up, remove the posterior condyles, and then do a posterior release. With this release, we are able to release the posterior capsule and get the extension gap. So this is how we release the posterior capsule. We should avoid using a sharp instrument so that you don't damage the posterior vessels. You gently release the posterior capsule. Once you release the posterior capsule, your extension gap is improved. This is how we are released. So this is the end of the procedure. We can see the fixed flexion deformity is released. I used a posterior cruciate substituting type of processes. This is the opposite side. Both sides are bilateral deformity. You can see the end of the procedure. The fixed flexion deformity is corrected. We leave it at 5-degree flexion because you don't want the capsule to stretch up and go into the curvature. So this is one more example of severe valgus with flexion deformity. You can see the patient walking with the stooped attitude, very neglected deformity. This required a constraint type of processes and the deformity is corrected. You can see the post-operative clinical image. The good correction has been achieved. Next, we talk about stiff knee. Many of the patients have fibrous ankylosis. So we start with the exposure medial parapatellar approach, and the patella usually has bony ankylosis on the anti-respect of the femur. So we need to osteotomize the patella to create a space. So we osteotomize, lift the patella up. Then we try to release the intra-articular adhesions. We use the diathermy, slowly release the intra-articular adhesions and try to get a range of movement. So this is after patellar osteotomy and early release with only 0 to 10-degree flexion possible. Now we do an intra-articular release and try to gradually release the arthropibrosis. It has to be done very slowly. The bone is very osteoporotic, so it can have an intraoperative fracture or ligament avulsion. Patellar tendon can get avulsed. So you need to be very careful when you're doing this release. So once you do this intra-articular release, we get a better range of movements. Then we complete your tibial and femoral osteotomy. So the steps have to be done with a lot of caution. So this is the end of the procedure. We have a good range of movements. We can see almost 100 to 120-degree range of movements can be achieved with careful surgical technique. So one more example where the presentation is very delayed presentation, totally stiff knee. You can see the patella is almost fused with the femoral condyle and the quadriceps tendon is contracted. This patient has been having a stiff knee for almost 10 years. Here we do a tibial tubercle osteotomy, open up the joint, then do the procedure. Then we proximalize the tibial tubercle osteotomy and fix it so that we gain some length in the quadriceps mechanism. So bilateral stiff knee, both side osteotomy, proximal displacement of the fragment and joint replacement has been done. This is after healing of the osteotomy. So right side she got almost 90-degree flexion. Left side it's almost 6 months follow-up. She has 80-degree flexion. So it will gradually improve. So our aim is to get 90-degree flexion. Next common deformity is valgus deformity. For a minimal valgus deformity like this, we do a standard medial parapatellar arthrotomy. We do a stress test under anesthesia. So we do a posterolateral capsule release and IT band release. They're described by Ranawat. It's called the inside-out technique. So this is what we do for a mild valgus. We get good correction and any type of process can be used, either a CR knee or a PS knee. In case of severe valgus deformity like this, we do a sliding lateral epicondylar osteotomy. We slide the lateral condyle with the attachment of the LCL and the popliteus and correct the deformity and use a posterior stabilized prosthesis. So one more example, right side is severe valgus, left side is mild valgus. We always do a stressed X-ray to know how much deformity is corrected. Left side is fully correctable. Right side is partially correctable. So left side standard PS type of prosthesis with the inside-out technique. The right side we used posterior stabilized processes with the sliding lateral epicondylar osteotomy with a post-operative alignment X-ray with a good deformity correction. So one more example of severe valgus where we used computer-navigated surgery to help in deformity correction and accurate restoration of joint alignment. So some patients have very stiff valgus and the amount of correction is too much, which cannot be managed with the conventional process. where these type of cases where the soft tissue is very poor and the bone is very osteoporotic, we directly go for a hinge type of processes. So when the deformity is very severe, MCL is incompetent, bone is very osteoporotic, better to go for a hinge type of process. Next, we come across hip and knee arthritis, combined deformities. This patient has severe fixed flexion deformity in the knee, more than 90 degrees, is ankylosed knee. The hip also bilateral arthritis. We can see both hips are arthritic, both knees are arthritis, and right knee is fused. So here we need to do the hip joint first, as Dr. Pannag explained. We start with hip, knee, and ankle and foot. So right side, we did the hip replacement first. Then we did a hinge type of processes for the right knee. Then we did a hip replacement on the left side and orthodesis on the left knee. This is a post-operative X-ray. Both hips replaced. Right knee, we used a hinge type of processes. Left knee, we just did arthrodesis. This is a post-operative walking video. The patient was totally crippled and she is an Ayurvedic doctor. Now she is able to walk and she is returned to her practice. So many patients have hind foot valgus in rheumatoid arthritis. We need to address this before starting your treatment. You need to tell the patient after the knee replacement, this hind foot valgus deformity has to be corrected either surgically. Otherwise, the medial collateral ligament is under constant stress and the knee replacement will fail. So we need to counsel the patient that patient need to undergo an ankle procedure to get the proper alignment of the lower limb. Many times the patient present with high CRP, we attribute to rheumatoid arthritis. This patient is a case of rheumatoid anti-CCHP positive. CRP ESR was high. We did a conventional total knee replacement. But intra-op, we found the tissues were doubtful. We sent it for gene expert. It came as gene expert positive for tuberculosis. Sometimes you can have coexisting infection. Anytime you see some granulation tissue, always send it for culture and TB culture. In India, patient on DMARDs, DMARD is the tuberculosis infection, co-infection is very common. So if you have any suspicion, always send for TB culture and biopsy. This is again one more example of typical rheumatoid presentation, but in drop we found a lot of granulation tissue. It's always useful if you can stage it. You can do a thorough synomectomy, wash it, send the tissues for biopsy and culture. Or if you already done the tibial osteotomy and femoral osteotomy, you can put a spacer and come back in a second stage to do the TKR. So this patient, all the cultures were negative, TB negative. So went back and did the TKR and patient is doing well. Always this, as we discussed, there are multiple complications. So TKR and rheumatoid should not be taken simply. So this patient had intraop ligament avulsion of the MCL. So I have to use a constraint type of processes. Prosthetic joint infection incidence is slightly higher. This patient has multiple rheumatoid problem, Winsub deformity, hip arthritis. Patient was on biologic drug. I did the both knee replacement. Patient came back after 6 weeks, 2 weeks of the acute infection. So I had to go in again, debrided, sent for culture. Culture grew staph aureus. Patient was on igrutamide, a synthetic small molecule. Patient was taking it pre-op and patient went back and restarted the drug. We cannot be sure that this is the drug which caused the infection, but they are more prone for infection. So we need to be aware of it before we contemplate the surgery. So total replacement in rheumatoid arthritis gives excellent results in spite of increased complication. Needs meticulous planning and attention details to avoid complication and give good outcome to a patient. Thank you for the opportunity.
Thank you, Dr. Raja. You have done great justice to the topic of technical aspects of total knee replacement and have also discussed challenging problems in which fibrous or bony ankylosis was there in the knee and there were infections. Luckily, they came out to be tuberculosis. So the complexity of problems are there in rheumatoid, but they are all solvable. Thank you very much. Now is the turn of our very own Dr. Yogesh Kamath from Mangaluru, who has taken the lead, and it is because of him that this webinar has seen the light of the day. So Yogesh speaks on total hip replacement and various considerations. Dr. Yogesh, please.
Thank you, sir. I'm just trying to share my screen. I'm, for some reason, just having a little a snag here. I don't understand. I'll just try it again. It's not sharing yet for some reason. Sorry.
Okay. Can we switch over to another topic and then come back to you?
Yeah, maybe for some reason, it's
You
just.
take a minute. Take a minute.
I'll just try this. It's.
Sir, in the meantime,
Right.
May I ask just a query to Dr. Raja?
Yes, sir.
Yeah, Dr. Raja, what is the the serial in the lower limb if the patient is with rheumatoid arthritis? How you go, whether it's the hip first or the knee first or the ankle first?
So first is hip first, and then mostly it is which is the most symptomatic joint. The patient has more the knee, it's knee first, or it is hip first. Sometimes you have combined deformities, both hip and knees. In this situation, we start with the hip first, then we go to the knee. To do knee replacement, we need at least 90-degree flexion in the hip. So we'll make sure that hip has 90-degree flexion, then we can go ahead with the knee. But if the hip is fused, we cannot do a knee replacement. We have to modify the table, it's more cumbersome. So always we start with the hip, then knee, then an ankle.
Right. If I can intervene.
Yes, sir.
There has been a teaching that in the lower limb, you type permutation combination of deformities, but one can go for foot and ankle first, hip second, knee in the last, unless, as Raja has said, which one supervenes.
Yes, sir. Yes, sir. It depends with the amount of involvement of the joint. But sir, ankle is last, as Dr. Raja has said.
No, sir.
First is always the forefoot. Then you go with the hip, knee, then the hind foot, and then the ankle.
As such, Dr. Chinmay, as such, the ankle failure rate is very, very, very high in cases of rheumatoid as compared to the normal joint.
Yes.
So, and the reoperation rate and the revisions and the loosenings are also very high. So it has to be last.
Yeah,
and
it goes
be
the
prepared
last.
for the arthrodesis if anything goes wrong.
Yes.
But one technical
depends, as he has already pointed out, that it depends on the severity of the joint involved, and it varies with the patient to patient.
Of course.
Raja wants to intervene.
Raja, please. You were trying to tell something.
I agree with Dr. Jha, what Dr. Jha said, because if your ankle there is severe deformity, when you do a knee replacement and patient starts walking on it, the medial collateral ligament will fail. So if the foot and ankle deformity is severe, we advise them to do the foot and ankle deformity first, then for the knee surgery. If the ankle is not severe with mild hind foot valgus, then we go ahead with the knee replacement. That sequence is okay. But if the severity of foot and ankle deformity,
yeah.
Raja.
Actually, Dr. Jha,
yes,
the teaching was there for a long time. So last 50 years, the teaching was that if there is no hip, no knee, no foot, like that. If there is no hand, no elbow, no shoulder. So that was the system for the weakness of the muscles. Whether it can be utilized for the rheumatoid or not, that is difficult. As Raja has told, that if there is deformity in the ankle and foot, so if you do this knee replacement,
yes, Yogesh, please.
Yogesh, finally you have got
Yogesh
it.
has come. Yeah.
I'm really sorry for the problems. Some technical snag with some software download.
Yogesh, you allowed us to discuss. Thank you.
Continue, please.
Thank you. So finally, greetings to all, and I'll take a deep breath as well. Welcome from Mangalore. I am going to continue with technical considerations for hip replacement in inflammatory arthritis. After Dhanasekar's excellent lecture, my job becomes simple. I'll directly go on to the points that we need to address in hip replacements. And these indeed are specific to the hip. So, oops, for some reason, again, I'm having 1 second. I'll just go on to, I'll negotiate it from the screen. Yes, that is better. So we can have multiple joints, and the timing of individual joints has to be carefully considered. The timing, as Raja said, in relation to DMARDs. Now, as far as biologics are concerned, definitely there is an ARA guideline for how long to wait, depending on the half-line of the biologic. But in terms of methotrexate, which 90% of patients are on, we have our data of over 150 patients over the last 5 years itself, with continuing methotrexate around the surgery and no wound problems. And we know that works. Now, multiple joints and the relation to each other have to be considered very carefully. Of course, there's going to be osteoporosis. We have to worry about the effects some biologics might have on bone incorporation, as failures and complications are known to be higher. Mobility issues of the patients have to be addressed. And what I meant with this is also thinking about some orthotics they might need. A lot of rheumatoid patients will have foot problems, which will change with respect to how we correct deformities in the joint replacements. And therefore, it also becomes the arthroplasty surgeon's duty to go beyond the call of just the joint replacement and think about how other specialists, as in therapists and orthotists, can be used to help with the patient's mobility. Of course, coexistent pathologies. I have also had cases of TB existent with rheumatoid, which have to be tackled along with other, DMARDs that the patient is receiving, of course. And of course, careful implant planning, which I'll try to show with certain examples. So rheumatoid is known to be wrought with complications. So therefore, make sure you just don't go in for the joint replacement, plan your case adequately. Specifically in the hip, in the acetabulum, we've had a chat with Dr. Bhushan, who talked us about presence of protrusio. There is going to be smaller sizes of patients, and particularly there are implants where you may not be ready with certain small sizes. So look out for these. Do a little bit of templating. Standard small sizes of implants may not go into patients, particularly the juvenile rheumatoid ones, because these have dysplastic features as well. We'll talk about orientation and how that changes with deformities, with examples of cases. In the femur, of course, avascular necrosis is more known in rheumatoid, but also you've got problems with small sizes and the existence of other coexistent deformities. Of course, because there can be stiffness in multiple joints, exposure and orientation during the surgery are of utmost importance. So what I will do is I'll go ahead to specific examples and probably try and drive home these points. Now look at a case here. This was actually non-rheumatoid. It was a case of angstpond related protrusio. So it is important that in angstpond you don't really have just ankylosis. You can get these variant features. You can look at this guy's SI joints. You can't really see them, and he's got protrusio of the hips. So protrusio is a common feature, rheumatoid or otherwise, and it has to be tackled for the case. So such cases with grade 2 protrusio can very well be tackled in younger patients with cementless cups. You have the head there, which you have taken out. You have to, in such cases, be careful. You may not be able to dislocate. So in situ neck cuts and take out the head, and you can use the head as has been used here to fill up the and build up the medial wall of the acetabulum. The acetabular implant can be used as a rim fit device. And in both these cases, you can see I have used a multi-hole type of cup, which gives a very strong fixation initially. I have used it in bridging mode where I have used screws in the ilium and the ischium in both these cases, where the central graft is able to load in impaction. You can weight bear with good fixation right from day one, which definitely helps for the eventual outcome of the patient. What I want to show here is a look inside into the cup in protrusio, followed by you ream this, the reamer will go more inside. Be careful not to ream with the smaller reamers all the way. As long as you've exposed the bone, ream the periphery, feeling the rim and the wall, because the walls could be thin. Don't over ream just until you get a good rim fit. And a little video here to show in this case how a little impaction grafting can be done. So that's morselized graft from the head, which is available in every single case. So you can put it inside after reaming. You can use a large size head to just impact the graft in. So I've used a 36 size trial head, even though, it may not be possible to get these big sizes of head into small patients, but it's not the final head. You're just using it as a gentle impactor. Don't use that for firm impaction, because a good impaction can then be done by the same last reamer in reverse reaming mode. Reverse reaming is a small tip which can be used by most surgeons and very easily available on table. Reverse reaming helps to impact this graft before you can knock the final cup in. The final cup in such cases can very well be cementless. Cementless cups have very good or better longer term outcome, and they have to be impacted slowly and softly so as to get a nice rim fit in those cases. Now, another example, complications are well known. This was a 79-year-old. No, I'm sorry, she's now 79. She was 72 at the time when I had done the joint replacement, and she was not walking. As you can see, she had an autopelvis. She was not walking for a good 12 years with this. Now, because of the pelvic discontinuity on the right side, there isn't as much a discontinuity on the left. I thought I will do a bridge plating and then do a cemented cup. But by the time I was cementing the cup, the plates gave way because the bone was so osteoporotic. I had plans of a mesh otherwise if I couldn't put a cup in, but the cup eventually had a reasonable fit. My plates got loose from the ischium by the time I put the cup in, but thankfully that cup has held in position. I've been taking x-rays whenever she comes back. She just walks around the house. I mean, you don't expect much walking after she has walked for not walked for 12 years at 72, but she's managed to. That is the x-ray at about 5 years post-op. So we've managed that despite the complaint. On the other side, of course, I've done cemented stems, but the cup is cementless because I got that in bridge fixation mode with a good graft incorporation, as you can see. Now, similar case, younger patient, but rheumatoid and features of dysplasia. So she had multiple epiphyseal dysplasia and that rheumatoid. The features I want to put across with this case is a complication. So look at the thin canal there. Look at the dysplasia with open acetabular and of course, not very strong bone. And what I didn't have, so I'd like to show you these complications so you can be prepared for these cases. What I didn't have at the time is I relied on, this was a relatively huge lady, huge on the outside, but very small bones inside. So I thought this would take easily the smallest size of the cementless stem. She was only 45 when I got it done. And that was the smallest size of the stem available at the time. And you can see that just didn't go in. So I otherwise had the chance of taking it out and knocking in a cemented stem, but my neck cut was good. So I've lengthened her by about 1.5 to 2 centimeters there. It wouldn't come out after impaction. So I was forced to leave it there. And I thought I'll correct it, leave the other side long when I do the other side. Now, the other side, I got, they did not have, this company does one size smaller, but they did not have it in stock in India at the time. So I had especially ordered it for the other side. When I did that other side, suddenly I was surprised that it was holding initially, but as you can see, it went in. Here I knew I had left it proud a couple of, almost 2 centimeters, but here it went in easily till almost half a centimeter above my neck cut. So I was surprised as to how it did, but everything else seemed okay. But I was a bit surprised, so I repeated the X-ray. Now, retrospectively, I'm seeing this here. I did not see it on the first post-op day, but you can see that on the 4th post-op day, and that had sunk in. My heart sank with that as well. But, the patient was, I did not want to go in immediately because she was painful, though she was, able to stably flex and extend her hip. So I kept her touch weight bearing and fortunately managed with that, even though you can see this prosthesis is only proximal weight bearing. So the lesson I've got from that is in such cases, always I keep a cemented Exeter standby because that small cemented baby Exeter will go into any goat. It will, I call it a veterinary prosthesis. And sometimes in such cases, you have to use almost a veterinary prosthesis. So the lesson learned by me from those, and that case, was to keep a smaller stem, a small cemented Exeter is smaller than any other stem made on earth, even though this was the DDH stem for that particular company. So even the smallest cementless may not go. That is the take-home message. So careful planning and execution can make a difficult task to achieve easy. Few more examples. So be gentle where you have to be and look tough where you have to be. That is the message. Another case here, this was a 25-year-old girl when we did it, and you can see clearly avian from high dose of steroid having been given for a juvenile condition and bad avian on that side. What I wanted to confirm was that she was walking with a lot of stiffness on this hip and had a functional scoliosis, though she did not have much of a fixed pelvic obliquity. So I wanted, looking at this, wanting to see changes on that side of avian before I went and did that, because I thought I'll do an intraosseous bisphosphonate at the same time. So what was surprising and what I learned from that case is I did not see avian in the head. As you can see, it was metaphyseal avian here, but more so and surprisingly so, can you see that cortical necrosis on the operated side? So that was my lesson learned. I don't have to do a cementless even in somebody that young, and that has turned out to be the youngest cemented stem I have done in a 25-year-old. She's doing very well at, she is now 30, so 5 years down the line. I know that Exeter will last forever. So Exeter, when it's done, it has to be done with a good third generation cementing that will last very well for younger patients as well. So by default, my design, the longest lasting design we know from literature is cementless cup with cemented Exeter. So that can be done. This is just to show you example of a third generation cementing. So that is a canal lavage followed by vacuum mixing in the gun itself every time. Use of a pressurizer after that same gun is used for injecting the cement, and very, very slow insertion of the stem with a centralizer, with a stem centralizer, that is, insert it halfway, stop there, and then insert it further on, making a little cement collar on the top. So little points for cementing there. Now look at this guy. He was looking all right till he was sitting. but when he stands and walks, that is him. He was not able to walk and look forward while he was walking for donkey's years. And that was his hip there, as you can see, ankylosed in over 90 degrees of flexion with an ankylosed spine as well. This young chap unfortunately developed ankylosing spondylitis when he was 16, and he came to us when he was about 28, having not been able to look forward and walk. So such severe hip deformity can obviously be corrected with a hip replacement, but be careful there when you have coexistent fixed pelvic obliquity and such a spine deformity. There are known calculations. So what you do in such cases, can you see this is an outlet view of the pelvis post-op? Why is it? That's because he's got fixed spine obliquity there. So in such cases, there are known calculations. You have to relatively retrovert the cup. So be careful, because otherwise you will have a higher rate of dislocation in these. My trick in such cases is, obviously, as you can see, I have kept the cup a little more closed. So that gives it a lot more stability. And this particular case, along with all that, I had to do, because it was over 90 degrees of flexion deformity, I had to go anteriorly and do an iliopsoas release as well, the type we do in cerebral palsy. But very thankful at the end. And that's how he sends pictures of himself not being able to walk with, with the leg on the ground. If his leg was on the ground, his head had to be down. And fortunately, he's got about a 30-degree flexion. That's because of the spine right now, but he's able to, do his activity very well following the hip replacement. Similar other cases, that is a case of arthrodesed hip in childhood. So those kind of cases will happen, and this is what the surgeon had elected to do at about an age of 20 for this patient. The patient survived with that arthrodesis for 35 years, but then started developing other wear and tear changes in the joints, which is why we had to turn it down and do a hip arthroplasty. My option there was really, not having a good region to saw through. I elected to purposely cut down on the femur rather than cut into the acetabulum. The acetabulum, of course, once you localize it, you always get the fat pad. Once you get the tal, it is very easy to find the acetabulum and ream it properly. Lots of bone, so easy fixation. But on the femur, that's I mean, of course, I could have just used a vaginal stem there, but I've just used this so as to get a little metaphyseal and distal fixation to get a good fixation there. Counseling this patient when you turn down an arthrodesis is they will get mobility at the cost of stability. So she has got abductor function, but you might have to counsel them that with the lever arm, the abductors are going to be poor. She can do abductor function. She can manage anti-gravity abductors, but she obviously has a little bit of a limp because they are not strong enough to, make her walk long distances. So that has to be counseled. She's obviously still very happy at 70 years after having this turned down. So as regards orientation, we know we orient the acetabular cup for anti-version, but it's not only that plane we need to look at. We need to think of version on and inclination in different angles. There are people who keep pillows in between the knees when they do their acetabular reaming. So remember that the pelvis might be tilted the other way around and the cup might look a lot more open than it actually is. So look at it from the point of your bony landmarks and looking at the TAL even in every rheumatoid, every protrusio, you will still have that TAL intact, which gives you the landmark for the cup position. Now, again, a case of juvenile rheumatoid, you can see that. Now, examine the joint above, joint below, and the joint above, as you can see, was a big surprise. So in such cases, don't go for correcting the true leg length, correct the apparent leg length, because that pelvic obliquity will not be corrected. Obviously, that is fixed. And that is what we did. Along with this, the patient again was very, very disabled, moving around in a wheelchair, but thankfully, and very bad knees again with 40-degree flexion deformities and just about a 20-degree arc. Here, I won't go into Dhanasekara Raja's territory. I managed a primary TKR because we got stability, but what I have to be I want to talk about in this case is very, very small bones, very, very difficult to rod the femur. We managed. So such cases are, cases where you might have at least the PSI, or if you don't have navigation, try to get some jig where you may not be able to, see your femur. Again, in cases like this, you may not be able to do a stem tibia. So plan in advance. This is indeed a very narrow tibia. This patient had a very, very difficult spinal. They couldn't do a spinal. They had to do a GA. The endotracheal intubation was extremely difficult. Fortunately, they managed with a fiber optic scope, but otherwise they were actually considering a tracheostomy or
Dr. Dilip, excuse me. Dr.
Yes,
Dilip, you please
Yeah.
mute your mic. Mute. There is adventitious sound from your end. Mute yourself. Thank you. Proceed.
Thank you. So just the last couple of slides, there are increased rates of skin problems known, not only because of DMARDs and methotrexate. Methotrexate will not cause wound healing problems, but we know their skin is very, very tender. So what we have done is we have developed this dressing. I do this dressing in all arthroplasty primarily, particularly for knees. We've managed very well. We've written it up, got it published, where what we do is just use colored gauze. So if there's a little bit of spotting in the wound, it gets very well contained. And we use large tegaderm because these are cases which have taken some time. We've corrected huge deformities, and they have higher chance of getting blisters post-op. So a large coverage with tegaderm allows the area of coverage over the blister. If it's a clean wound, we definitely don't need to go down and do wound checks in them. We manage to get these wounds directly opened at 12 to 14 days by when those superficial abrasions and tender skin has healed. Because doing wound checks, particularly on tender skin, can give more chances of having skin problems in the post-op period. So what we call it is the hands-free dressing technique. Again, in cases which have a large intraoperative synovitis, which we talked about, I confidently, with good theater techniques, I put intraarticular steroid in my local infiltration analgesia, and that definitely helps them get better mobilization in the early postoperative period. This is well documented in various LIA protocols. Thank you very much. Thank you for a patient listening.
Thank you, Yogesh, for talking about various permutation combination of deformities located in the hip, and also talked about associated spinal and pelvic obliquity deformities as well. Well, now is the turn of a very much needed aspect of rheumatoid, in which all of us know the hands get deformed. And Dr. Praveen Bharadwaj, originally I thought he's a plastic surgeon, but later I know he's an orthopedic surgeon into hand surgery. So Dr. Praveen from Coimbatore, he speaks on replacement or reconstruction of hand deformities.
Dr. Navin, you are there?
Yes, sir. Yes, sir. I'm here.
Okay, so
Thank you.
very good. Dr. Navin, we are so happy to see you here. This is our last, during this year, the 7th webinar, and we are happy that you are here to witness it. But before we proceed on to the next lecture, I would like to have few words of wisdom from you.
Yes, sir. Yes, sir. Sir, I forgot because I was busy in preparing the CME program of Gujarat Orthopaedic because non-union. Suddenly, Dhaval Desai said that he will not be able to come. So the whole duty has come to me. So I was busy. I forgot it.
I know.
And 9 p.m. we are meeting for all scientific program, complete scientific program.
Right.
Sorry, sir, I could not attend in the initial part. Dr. D.P. Bhushan sir rang me just now, so I joined it. And it's a fantastic that your committee is the committee who has done the maximum webinars, sir. And with the maximum content and a good content. So I will recommend to Dr. Sen sir that as we are given the last year, that should be a special award to this committee also.
Oh, and
Yeah,
I'm happy,
That will be
Doctor.
my that will be my recommendation. What happens, let us see.
Rather, I was also expecting it that rather I was to say that if there has to be award, it has to be to this.
Sir, you are here. I don't know, sir.
I'm very much here.
Sir, yes, this committee and IT committee has done a wonderful one. I know that IT committee has worked very hard because it was very tough task they have done, and this committee has also done a good job. Maximum webinars with maximum content, timely done, good faculty, everything is good, sir. Thank you, sir. You can go ahead with the academics. I don't want to disturb academics.
Thank you, Navin,
Right.
for keeping my request. Thank you.
Thank you, Navin
Okay,
ji.
sir. Okay, sir.
Thanks. Okay, so now is the turn of Dr. Praveen Bharadwaj, our very own orthopedic surgeon turned into hand surgeon from Coimbatore.
Thank you very much, sir. It is indeed a pleasure to be here. And as you rightly told, the hand deformities actually come first with rheumatoid arthritis. But fortunately, these days the deformities are much lesser. And I think the previous generation of hand surgeons than me were kept fully busy by rheumatoid arthritis. But all of them remember that it was a most difficult thing to handle in hand surgery. And they are very happy that the patient profile of rheumatoid is changing, thanks to the good anti-rheumatoid treatment available these days. And we hardly treat any patient in the acute stage now. And the spectrum of patient has dramatically changed. Previously, we used to be very busy treating synovitis. Synovectomy was the commonest operation, but I don't remember any synovectomy what we have done in last few years because of the good and early appropriate treatment what these patients are getting because of our rheumatology colleagues. However, the severe deformities do still come now and then, and these deformities are quite severe, but they are silent. They are not too painful, but they deform the hand too much, resulting in severe functional disabilities. And since the deformity is generally bilateral and involve multiple joints, it is quite disfiguring as well as functionally disabling. The other thing what we commonly see is the tendon ruptures, though it is reduced in intensity because of the better management at the inflammatory stage, but still it is commonly seen. And this is one of the easy things to correct because generally it is a partial rupture and we can do a side itching with the side tendons to get a good result. However, when the patient presents in advanced arthritic stages, as we have seen in the hip and the knee joint, we have various arthroplasty options available. Now, treatment-wise, it is good to divide the rheumatoid arthritis into 4 stages. The first one being synovitis with joint deformities, and this is quite well treated by medications. The last one is where there is a diffuse articular destruction of all the joint. And in these stages, we do have a lot of options available for arthroplasty, like silicone, even pyrocarbon or metal prosthesis available. Not very readily available in India, but we have options. And the principles are almost the same. You correct the deformity, and if the articular cartilage is damaged, we get a prosthesis inside, and we can generally get good result in these patients. But unfortunately, with less demand among the surgeons, these prosthesis companies are not coming up with very good options in India. However, the silicone joint is a commonly thing which we do for these patients. Often the patients, when they come, the main complaint what they have is the pain. And one of the other good things which can relieve pain is a fusion. And fusion is quite well tolerated in the hand because one joint quite easily compensates for the lack of movement in the other joint. As in distal radial ulnar joint, if we fuse the DRUJ, we can create a joint proximally in such kind of Sauvé-Kappanji operation, and we can get quite a good result. However, I would spend little more time on talking about correction of deformities, because that is quite very peculiar for hand. And since the arthroplasty options are quite standard, as we do in the lower limb and the shoulder, in the elbow, but the correction of deformities is quite unique to the hand. When we talk about correction of deformities, it is ideal to do that when they are passively correctable. But even when they become fixed, they are quite very well correctable. One important thing to remember is the deformities are almost always progressive. It is just like a pack of cards. Once it starts falling, it will just collapse. So we can see over here, the hand does not look too much deformed. We tend to think like, okay, it should be fine. But once deformity as one joint starts on, it just really collapses the proximal and the distal joint, and it will very quickly progress to the advanced stage. So that is the reason why it is good to correct the deformities in very early stages. So one of the early indicators or early stage of the deformity formation is extensor tendon subluxation. So I think this is the stage at which if one patient is seen and identified and treated, he will really benefit the maximum. He will not have much severe deformities. So we can note over here, if we see in our finger, the extensor tendons remain right in the center of the MCP joint, just like this, which we see in the normal side. However, on the involved side, we see that the extensor tendons are at the MCP joint. The extensor hood is slid down onto the ulnar side. So it is called as a subluxation of the extensor tendon into the gutter. This is the gutter. And once it is subluxed down, it creates an abnormal extension force onto the PIP joint, causing a swan neck deformity. And once it has subluxed down, it goes volar to the MCP joint. And since it is volar to the MCP joint, it no more acts like an extensor. And that is the reason why it will cause progressive deformity in the finger as well. So it results in flexion contracture of the MCP joint, ulnar deviation at the MCP joint, swan neck deformity at the PIP joints. So it is good to identify these patients and correct at this stage to get a very good result. One of the main clinical signs is lack of MCP extension. So this patient, if we see, this is the involved hand. The hand does not look quite bad, but if we ask her to extend the fingers, she is not able to extend. And this is the clinical sign. See, the patient is able to nicely flex, but when extending, the hand is not going into full extension. And this is because once the extensor tendons are subluxed into the gutter, they are no more dorsal to the MCP joint axis, so they cannot act as an extensor. In fact, they remain on the flexor side and act as a flexor. And that is the reason why the extension at the MCP joint does not happen. And if this is left unattended, it will cause a swan neck deformity of the PIP joint because of overactivity at the PIP joints. There are various good options available to correct this extensor tendon subluxation, which is called a centralization of the extensor tendon. Our preferred option is we take a distally based extensor tendon slip and hook it onto the collateral ligament on one side, that is the radial side, pull it and suture to itself. The pull of the extensor tendon onto the MCP joint now would correct the subluxation of the MCP joint and also realign the extensor tendon. You can see over here in the other fingers, we have not corrected them yet. The MCP joints are subluxed on the volar side, the extensor tendon is down, but here the extensor tendon is come into the center. We have got a nice support for the extensor tendon to hold it in place, and it will stay in the center and will start acting like an extensor. This procedure can be done for all the four fingers at the same time by longitudinal incision or by transverse incision. This is a different example, but the previous patient we had done with a single transverse incision. If we are expecting the deformity to be much severe, we are requiring longer tendon graft, then it's better to go for a separate incision for all the fingers. If we are not expecting a severe subluxation, then we can go by a single transverse incision. But important thing is that all the extensors should come in the center and stay there, which has to be done by dynamically balancing these tendons by putting a tendon graft. And we can get a good result like this. We can see the extensor tendons are no more subluxing down. They are remaining in the center. And the patient immediately would appreciate that extension is getting better and it will get to normal in few months of physiotherapy. So this is the patient at about 3 months from the operation. And we can see the patient has got a good extension in all the fingers and there is no more alveolar subluxation. Now, when we are treating these patients, of course, the first thing what patient mostly comes with is the pain. Fortunately, with good medications now, they get very well controlled in pain and then they come for the deformities. In the upper limb, since the deformities are happening very slowly, most of the patients fortunately adjust quite well and they present much later. But whenever we are operating in these patients, if we see them early, even if they feel like it is not much functionally disabling, I am able to manage, we need to pick up the deformities which are progressive. And if the deformity is a progressive type, we need to suggest them treatment at that stage itself so that we don't require to do a much severe deformity correction. The main aim for all the operations in rheumatoid is to improve function. And also in younger patients, sometimes we also get an additional benefit of improving the appearance. Now I heard about a lot of discussion, nice discussion about which deformity to which operation to do first for the knee, for the hip or the ankle. In the upper limb and lower limb also, there is a good debate on which one should be done first. And it is overall thought that lower limb surgeries should be done before the upper limb surgeries, because patients, when we look from their perspective, they feel that their independence is lost if they are not able to walk. So that is the first priority. And patients can generally cope with upper limb deformities because they can balance the work between the two hands. But in lower limb, both have to be okay for them to walk. So just to make them more independent, to make them more comfortable, it is generally the lower limb operations which are done first. Also, for an indirect benefit region for the surgeons, that if the upper limb operation is done first and the patient is using crutches or walkers to walk around, they may actually create more problem to the upper limb joint, especially if we have done an arthroplasty. When it coming to upper limb, which deformity to correct first? Whether we should do everything at a time or we should do one at a time, and which one to do first. There is a lot of debate, but in general, as with many other conditions in orthopedics, it is better to do the simple operation first, because these patients generally have the deformity for a long time and they would have become quite expert in managing their activities with their deformities. So it is better to the operation which is a real winner, so which will immediately show that the patient that is much better. It is good to do multiple deformity correction if they are related to each other. For example, if there is MCP joint subluxation and swan neck deformity, they are related to each other. So it is better to correct both of them together. However, there is no need to correct shoulder, elbow, and wrist at the same time. It is in principle better to do the dominant limb first so that the patient becomes more independent to do their activities. But in some cases where we are not very sure what type of outcome we will get, or patient is quite hesitant, it is okay to do the non-dominant limb first. An example of both these approaches, so this patient, a 50-year-old gentleman with severe deformities on both the upper limbs, and he felt like he is not able to write, and that is severely disabling him, and he is not able to do all his things what he required to do. So deformities were quite severe, but since he was quite functionally disabled, we decided to operate on the dominant hand. We corrected all the MCP joints by centralizing the extensor tendon, reducing the MCP joint. Once the MCP joint was reduced, the swan neck fortunately got partly corrected, but it was further managed by central slip tenotomy to get an outcome like this. This is the early stage where the PIP joint wires are, we can see, still there, and the MCP is corrected. But in this stage itself, we can see how different the hand looks. It looks like it is going to function much nicely. Patient was quite happy with the appearance also. One good thing is, since both the hands are involved, even patient is having a real randomized control study, which you can correctly compare and see how different this hand is than the other hand. And this patient dramatically improved in function, and he was quite very happy with the outcome, and he almost was begging to do the operation on the other side. So that is the advantage when you have bilateral involvement. So if you do well on one side, actually you don't have to ask the patient for the operation on the other side. However, a similar type of case, a juvenile rheumatoid arthritis, this girl who was 19 years, these deformities are not very typical of rheumatoid. You see the volar subluxation, the ulnar deviation which happened is not seen here. Here it is quite different type, severe hyperextension deformity and dorsal subluxation of the joint. The wrist joint was totally destroyed, and the MCP joint of the thumb also is hyperextended and subluxed. So this patient, we decided to do the left side first. And this was the side what we selected, though it was not anyway more involved than the right side. Both the sides were like that. You can see very severe deformity. We did the fusion of the wrist, which gives lot of extensor lengthening over here, which allowed to correct the MCP hyperextension posture. And then we fuse the PIP joints to get a swan neck correction. And this is the function what this girl attained at 6 months. We can see she was right hand dominant before, but now after the operation on the left hand, she has started using the left hand more, and she is comfortably doing all the activities and just waiting for her 12th class exams to get over so that we can do the operation on the right hand as well. So to summarize, the deformities in rheumatoid patient fall into 4 stages now. The first stage, where there is synovitis, we did not rush up for surgery, and the medical management does quite well. In the last stage, where there is a lot of articular destruction, we would be happy if we are not able to reach that stage. And at that stage, the options are to do an arthroplasty or an arthrodesis, and both work quite reasonably well in the hand. But it is good to get the patients in this intervening stage where they have deformities which are correctable. At that stage, the joint is not destroyed, so we can retain the native joint and correct the deformities and dramatically improve their function to make them happy and remain productive in life. Thank you very much.
Thank you, Dr. Praveen, for making the hands look so functional. But I think you have rightly said in the very beginning that because the total number of output of joint replacement in the hand is so limited that the desirable joints are not available. I only wish and hope that the number increases and various joints are available.
Yes, sir.
Friends, thank you. Thank you very much. Now is the turn of our very vibrant Dr. A.N. Mukherjee from Kolkata, who has devised, after pretty long years of research, a shoulder joint, which he prefers to call not a Kolkata shoulder, but an Indian shoulder. Dr. Mukherjee, it is.
Thank you, sir. Thank you for your. Thank you, sir. Thank you for your kind words. I think I am audible, sir.
Yes, you are audible, and please remain restricted to 10 minutes.
I will try, sir.
Please.
Sir, is that slide
right,
you can see, sir?
Yes, slide is visible. Slide is visible. Amitabh.
Okay. Yes. Thank you. Thank you, Dr. Bhushan. So I start my journey with my shoulder and Indian shoulder. The concept starts long back in late 90s when I came back first time from England. There were some rheumatic cases, and when I started putting the prosthesis in, they failed. They failed miserably. So I thought, what's going wrong? So I went back and I did, and I find out that there is a lot of differences in cadaveric model. So my first thing came for the rheumatic shoulders, I mean osteoarthritic rheumatic shoulders and rheumatic fractures. So like the patients who had the rheumatism, they had a higher tendency of fracture. So thereafter, I started doing this cadaveric study. So in this cadaveric study, the 80 cadavers from all around the India was taken, and they have been calculated. Their outer diameters and inner diameters were calculated, and these figures were taken in consideration. Then this whole set of 80 cadavers were put in the X-ray plate, and they had been exposed, and the diameters and the parameters of the X-rays was taken in consideration. Thereafter, the retroversion was calculated. You can see the Indian retroversion is varying from 25 degree to 40 degree. That was my PhD thesis. And after that, I have found these anatomical parameters. On these anatomical parameters, I made the sketch of this final initial first generation of prosthesis, which has been assembled like this, which is a stain component of 110 cm. And that was somewhere back in, I think, 2004, which gave me Dr. Sushruta Award. Thereafter, the thing has been patented, and by grace of you, with all your blessings, Dr. Jha is there, Dr. Sen is there, with all your blessings, is the only patented shoulder prosthesis for whole Southeast Asia. And this has been exported to Europe and other places, Georgia and other places from India from recent days. Thereafter, this same prosthesis has been worked for biomechanical study. A load of 2.75 was elongated from the mid-shaft of the humerus, which is the average wedge of Indian arm. And at 20-degree pull was applied around the myosius anchorage of the rotator cuff. And it has been found that all the forces, oh my God, I don't know, whatever maybe, it has been found the forces, the vertical forces and horizontal forces are much less than the conventional prosthesis, and that makes the less chance of glenoid wear and chance of dislocation and subluxation. Thereafter, I designed it, and now it is available in sterile pack, and the thing doesn't end it. So the quest started that there should be a new generation, because the need for the modularity was wanted. So the same thing was worked for the modularity. This was the modular stem, and you can see the modular stem, how it has been worked. And so it was the total, in the span of the time, there was total somewhere around 276 cases in different, and the RA cases were 71 cases, like fracture, and RA cases where the primary replacement was there. So the surgical technique was just take out the prosthesis head like this, humeral head, then you put a myosius tie. This is the main success of the story, that the myosius tie or rotator cuff must be tied, and then you make the humeral canal, put the restrictor, mine it, and put a trial, and with the trial prosthesis in. This is the trial prosthesis in. Thereafter, you keep this lateral part free, because that has to be united with the main shaft of the bone. The GT has to be united. So thereafter, this has been closed, and these are post-operative, showing some cases. This is a pre-operative RA case, replaced. This is another old lady RA post-operative fracture, replaced. This is another head split fracture which has been replaced. You can see the face, she was an RA. There's another case which has been replaced, and this is a reverse dome of an RS. You can see the whole prosthesis was very old case, and the whole proximal humerus was looking just opposite, like a reverse shoulder. This has been replaced in uncemented. These are some cases, and these are some cases. I'm just going quick, fast, as Sir said. And you can, in this RA cases, you can have these fractures which has been extended up to the stem. If you can tie up your hip prosthesis, if you can tie up your total hip, you can tie up the shoulder also. So you can tie up it, and these are the certain cases. And this is one of Shornendu's case. So this was a failed case. So we just revised, and we did it like this. This is another case. This is one of the RA cases. This has been treated by some of our neighboring. Then I did it, but I was not quite happy that what will be the outcome. Trust me, this is one of the best outcome. And this is, I don't know, the video is not working. Whatever may be, let me try. Just one sec. Yes, sir. So that was the range of motion, you can see. That was
It's not visible. You can go ahead, Dr. Amitabh.
Can you see, sir?
No.
No.
Oh, sir, sorry. I thought.
You
Okay,
go
sir.
to the next slide.
Okay.
Hmm.
So how do I escape?
Yes, that's sorry.
Oh my God. Sorry,
Yeah.
sir. Sir, sir, can you see, sir?
Yeah, we can see 2008 Bangalore DAS where you are being garlanded with a medal.
No, sir, that is a different story. Sir, how do I go back, sir?
How do you go back?
You just press the button back. It will go back.
Escape, ESC.
Escape, I did, sir.
Escape.
Oh my God. I am just resharing, sir. Just give me 1 minute, sir.
Okay.
Sorry, sir. Sorry for the trouble.
Nice, okay. Please.
Now it is okay, sir?
No, same. Escape is not working.
Mukherjee, the escape.
Just 1 sec, sir.
Right.
Now it is okay, sir?
Started screen sharing. Yes, go ahead. Yes, first. No. Again,
Yes.
back to that. At least.
Click to some other slide, please. Click to some other slide.
Right.
Okay, sir.
Other than this. Yes.
Is the
yes
the need of the design of modularity was there, so I made the new design, modular design, sir. After that, this is the modular design, which are the modularities of the neck and stem and the head. And this is in some cases, I am very proud to say this is one case done from Bihar, one of my fellow Abhishek, I am forgetting his name, from Darbhanga. He did it. See that, and then this has been replaced by the same prosthesis. So the same prosthesis. This is another case. So I did a further study of CT study to see, and it was been found that it is absolutely anatomical with the same thing, and this can be used otherwise in other bony pathologies also. So this is one of the thing. If I say I don't have complication, I am lying. So I had complication for maladjustment of height in this RA patient. There was instability. So this is one of my very early case. This is an RA case. I extruded the stem, but she was happy rest of her life with this. And this is one of the migration of GT. I had infection, I had periprosthetic fracture, which has been taken care. So calculating at the end, I calculated all the results. It was UCLA 29.69, constant Male 53.68, and for knees, it was 81.38, which was satisfactory. But this was the time when these cases were coming back with glenoid erosion and pain. So I thought there is a time for a platform stem where we work out the same stem can be used for hemi, for total, and for reverse. So I went back, I did a drawing, and I did a 2D drawing. Thereafter, I did a 3D drawing, and this 3D drawing was put on animation of the model, and the same model has been worked in the simulation study, and the same simulation study showed in the bone model, and that has been found anatomically found and working. Thereafter, I did a 3D print, and the same 3D print was put on saw model, and saw bone model I have worked out. Once the saw model was found, then that has been put in cadaver for hemi, the same, keeping the same stem. I replaced it with the total, and the same has been replaced by reverse. So because in RA cases, the problem with this in coming days, the rotator cuff was going on, so these shoulders were not working. So I need something to do for which the same stem can be converted back to reverse in the time of time. So with this, I got this David Rowley Award for that. So this is one case I could do this for this prosthesis. Initially did with the hemi, then thereafter with the reverse. So with this was my journey. Thank you very much, sir, for giving me this opportunity to share my Indian shoulder with you.
Thank you very much. This was a long continued research, and finally perhaps you have got the best answer to the shoulder in the form of Indian shoulder. Now, please stop sharing.
Thank you, sir. Thank you, sir.
Well done, sir. Congratulations.
Thank you. Thank you.
Right. Now is my turn. You can see my slide?
Yes, sir.
Is that okay?
Yes, sir. Yes, sir. Yes, sir. We can see.
Okay.
Yes, sir.
So friends, everything has been talked about and not much has been left for me to discuss. But the perioperative considerations, I wish to present this case. The other hip is not visible, but in a case of ankylosing spondylitis, both the hips are similarly involved. This patient presented to me on 2nd April 2018. He is only 20 years, presented with left hip for painful for 5 years and was unable to walk beyond 1 kilometer. Right hip had pain since 1.5 years. On examination, as you can speculate, all the movements of the hips were restricted. I really did convince him that surgery is the best answer. He was not ready, and I also became enthusiastic and started treating this patient with etanercept sulfasalazine combination initially for very limited period steroids, and only in 3 weeks treatment the patient came running and claimed that he had marked ability with a marked relief with ability to walk effortlessly even 2-3 kilometers or longer. I added some methylcobalamin gabapentin and the treatment with etanercept continues. And on last follow-up, this is the X-ray in which you can at least have something like a joint there. And let us look into what the patient has achieved. He can squat, he can sit cross-legged. This is still his back because it is a patient of ankylosing spondylitis, the other ones. And now come to case 2. This is another case. I have been treating him for last 6 years. Last he has come to me on 15th March 22. On that day is this X-ray. And on that day, this is his spinal X-ray. This is the kind of movement that he has gained back. So, friends, what happened? No. Okay. I think I did load some other presentation, but okay. This was one message that I wanted to give, that joint replacement is definitely a definitive management, but with biologicals available with you, you can treat these patients, maybe not very uniform joint, but the patients are really happy. One thing I would also like to tell a story. A patient came from Chhattisgarh, very bad hip. I said joint replacement will be required, but then he came with all the prescriptions of a similar patient treated by me who was from Chhattisgarh and said, you have restored, the patient has restored all his hip movements. Why will you not treat me with these drugs? So this is worth a trial. Even in late cases, before you contemplate, hip joint movements can get restored. I would like comments from Dr. Raja, Dr. Yogesh.
So definitely in a younger patient, we should consider all the possibilities before we can jump into a joint replacement. So always we make sure they are on adequate dose of rheumatoid anti-rheumatic drugs for adequate time. And always we consider newer biologics also before we can contemplate whether as we can delay the surgery for these patients better, because anyway they will recur a revision joint replacement after a few years. So in young patient, better to try to avoid joint replacement as long as possible.
Right.
So I absolutely agree with Dr. Jha. If the biologics could help them, we should try to start them on biologics and try to delay the joint replacement as much as possible. And a lot of patients have good relief with biologics and they're doing well. So I think should be considered.
Right. Thank you.
So just to add to Raja's comments, with a hip, I mean, I totally agree with what Raja said, as much delay as possible. The factors that might say that, surgery eventually will be required are probably the extent of deformity and coexistence of other deformities and other joints as well. Now, to a large extent, we have seen fair bit of deformities, correct, but on examination, when we see a very rigid fixed deformity, we know that is not going to change much. Particularly again in X-ray in the young patients, if we see there is bony ankylosis, then probably there is no point waiting with hips. Right. That is the only clear excluding point. If there's bony ankylosis in hips, I wouldn't wait for longer, because nowadays with hips, we are not really shy of doing it in young people, because with the materials available, we could probably potentially make hips last for even 50, 60 years. With knees, totally, even though there are deformities, if they are functional, RA patients or any kind of poly-inflammatory conditions will be able to manage. So unless there are other joints which are getting permanently affected, we can certainly even consider some orthotics along with the new biologics and prolong the possibility of joint replacement.
Right. Now I hand over it to Dr. Dilip Mazumdar.
Thank you, Dr. Jha. Very encouraging discussion that you are, and I was really awestruck to see the clinical results of your cases from Jharkhand or from neighboring places. This actually what it comes to my mind. Even Dhanasekara Raja and Yogesh, I tell them that thorough clinical examination is first. So there is no substitute for the thorough clinical examination. He told that if there is an ankylosis, if it is a bony ankylosis, then you don't wait for this conservative treatment. Go for the replacement or surgery. So thank you, Dr. Yogesh, and thank you, Dhanasekara. But I must thank Bhushan sir, for his good speaking capability, and I also thank him that he has called Dr. Thakkar. We could not have seen Dr. Thakkar here, and Dr. Thakkar has given us the message, important message, that for a long time, many years, we are doing this. This association is doing so much work for the IOA. He has told that, and also endorsed by Dr. Sen also. Actually, Manoj, you all know Manoj is a very good speaker. He has actually told about the outlines and all that. And Pannag Bhushan has also told many things about that. Dhanasekara Raja, one thing I remember from Dhanasekara Raja, because of time I am quickly summing up. Dhanasekara Raja has told about the ankylosis of the patella in the TKR cases. So I remember from Dhanasekara Raja's this story, long ago, I did ankylosed knee rheumatoid, and I had to build up the patellar tendon, avulse the patellar tendon from the tibial to porosity. So from that, I was very much actually cautious about that. In those cases, I had to release those this insertion with a block of bone and then again reinsert it later. thank you, Dhanasekara Raja, for your nice, because of this ankylosed cases and mostly the valgus cases that he has told about. Ankylosed cases and valgus cases really awestruck. And the results you have shown are really wonderful. Then comes to Yogesh Kamath. Yogesh Kamath has got the issues. Yogesh Kamath has told one word. Do you remember that? Veterinary prosthesis. Dr. Jha, do you remember?
Yes, very much.
So veterinary prosthesis he had told, and issues of this all adductor tenotomy and all that, and this protrusive cases, really wonderful protrusive cases. He has taken the help of the head as for the bone graft, and protrusive cases are very much available in the rheumatoid. We find that, and he has very nicely managed those cases. Yogesh Kamath, not only doing this surgery of THR, Yogesh Kamath has done a wonderful job for my friend also, because he lost 30 years ago, and he has actually responsible for reconciliation in Goa. So that I told Yogesh Kamath earlier.
Okay, I will stop, Dr. Dilip. My real presentation is here now. I will just rush through my slides. So the various surgeries.
Oh, I am summing up. Sorry.
No, wait.
I am summing up because of shortage of time.
Wait, I will just rush through. So the order of surgery we have been talking about: in the upper limb, it is wrist, hand, elbow, and shoulder, and the lower limb we have discussed. So it differs. Now, this one thing I wanted to say, which Dr. Raja has already said, that flexion contracture is more prevalent in RA than in OA, though in OA also it is seen. Posterior slope should be taken as 0. If there is less than 15 degree, posterior capsule stripping itself may suffice. And as Dr. Raja has rightly said, you can have distal femoral resection. So 2 millimeter distal femoral resection for every 15 degree of deformity, 45 to 60 degree preoperative manipulation and casting. And he rightly said PCR substituting techniques. And if it is more than 60 degree, preoperative manipulation and casting and constraint articulation may be required. Valgus, he has rightly said, rheumatoid cysts are there, not very patellar resurfacing. He has emphasized risk for infection is there. Then synovitis, synovectomy must be done if it is there, because later on there may not be flare. Well, osteopenia or osteoporosis is so very common, and there could be supracondylar fractures either during or maybe even after. Notching and post-operative stress fractures could be there. Intraoperative fracture of the patella are sometimes common, and so avulsion of the MCL can take place. And all of us experience spikes and retractors can dig into the osteoporotic bone. So one point I wanted to highlight, that cartilage and bone damage are there in osteoporosis, in osteoarthritis, also in rheumatoid arthritis. I would like to switch over this slide, but this particular slide tells us that osteoporosis must be tackled before and after management, and zoledronic acid, especially the special disodium zoledronate tetrahydrite, really serves the answer. Now look into this one total joint replacement. This was done in Mumbai, and this is the post-operative status in which the tibial one has migrated. Well, without any fracture, without any injury, such fractures can take place. And so, should DMARDs be stopped during surgery has really been answered, and the answer is that methotrexate can be allowed to continue, but steroids should be weaned. As far as TNF is concerned, the normal formula is stop or discontinue at least 4 half-lives prior to major surgery, which accounts for 2 weeks prior for etanercept, 6 to 8 weeks for adalimumab, 4 to 6 weeks for infliximab, and they can be restarted postoperatively if there is no evidence of infection and the wound is healing. Well, you can catch them young and you can treat them. Monoarticular arthritis, it is if there is inflammation, we must exclude infection, and aspiration will give us the answer.
I think Dr. Jha, it is another talk, I think.
No, fine, over. So the take-home message is failure after proper therapeutic measures only deserve joint replacement. Accepting the situations that Dr. Yogesh was discussing, order of preference must in polyarticular involvement, catch them young and treat or abort or prevent possible future joint replacement. Always remember, treat osteoporosis before and after replacement, and atraumatic fracture neck adjoining root joints are possible. Thank you. I'm so sorry. I had loaded another presentation.
Dr. Jha, actually, sorry, very sorry, Dr. Jha. I was actually summing up because of shortage of time, you know.
Dr.
So,
Dilip.
very sorry.
Now
Very
you
sorry.
can go. Now you can go ahead.
Dr. Dilip.
No, I must, Bhushan, sir, I must thank Dr. Bhushan, sir, Professor
Dilip,
Bhushan,
sir,
because
Dilip, sir, before we sum up, I have a message from Atul Srivastava, which I feel
very nice.
We are obliged to read it here,
Yeah.
since it is our 7th webinar. Dear friends, good evening to all. My sincere apologies for not being able to join in person due to some family commitments. His daughter is getting married on 20th. I'll be visiting him. Arthroplasty in inflammatory arthritis is a very relevant topic, and we have esteemed speakers for the evening. I congratulate all organizers, Convenor DP Bhushan and subject expert Dr. SS Jha. Thanks the faculty and wish the delegate a fruitful evening. Long live IOA. Thank you very much.
So, Bhushan, sir, I added another feather to the cap. Bhushan, sir, you have added another feather to the cap today, this evening, because you called Dr. Thakkar. Without calling the Thakkar, Dr. Thakkar would not have told about all these things. He was busy somewhere. Okay, a second thing is the Srivastava story, a Srivastava note that you have read. Thank you. Thank you, Professor Bhushan. And we will remember your hip, knee, ankle, and the order of intervention of this processes and issues and all that. And the protissue issue. Protissue issue is very, very important thing that you have pointed out. So Dhanasekara Raja, most important thing of Dhanasekara Raja is about the ankylosing knee. So solution is the ankylosing knee and valgus knee. Very important for TKR. But the gap balancing also important. Osteoporosis also important. All things have been taken care of. And very, very important thing is not only the bones and the ligaments, but also the muscles are also weak. The muscles are very weak. The ligaments are frail. Bone is osteoporotic. And all these considerations he has taken, and very excellent result he has shown. And regarding, I told that the peeling of the patellar tendon that has occurred in my case long ago. So now Yogesh Kamath, wonderful. He has taken the protrusive stabile and shown very nicely the cases, very good results with bone grafts taken from the head of the femur. And he has told us one word, that is the veterinary prosthesis. Why he has told this veterinary prosthesis? It is always been explained. But one of the, who is actually man of the match? Man of the match is actually probably Bharadwaj. Why? Right? The teaching of the good teacher. He's got a good quality of a teaching. Hand deformities, and there's so much beautifully he has explained about the tendon rupture, and the advanced arthritis of the wrist, arthroplasty, not readily available in India, and it is the silicone prostheses are very much in use. So deformity correction and the series, and how the tendon have been soldered away into the groove, and how it has been corrected very nicely. He has shown simple operations. So I thank you, Pravir Bharadwaj, you come again and again and enlighten us in future. Thank you. A.N. Mukherjee, yeah, long train of research of the shoulder prosthesis A.N. Mukherjee has done. And now this A.N. Mukherjee, the shoulder prosthesis is very much popular in the Southeast Asian countries now. Professor Jha has already told about the ankylosed hip and nicely has told about the treatment, conservative treatment, which can actually avoid the surgery in some cases. And I added to it that the thorough clinical examinations in all the rheumatoid cases is important. So find out whether there is an ankylosis, whether it is a soft tendon field or hard tendon field, whether it is ankylosed, bony ankylosis or it is a fibrous ankylosis. All these things have been already highlighted by all the golden speakers. So at the end, I must thank all the golden speakers and our convener, Bhushan sir, and Professor Jha, the backbone behind everything, for coming for the future of this new enlightenment again and again with the golden speaker to see in the forum and enlighten the whole of our medical fraternity and have a very very prominent position in the IOA. Thank you, everybody. I thank you. Thank you for joining us in this evening. We have overshooted the time. Sorry for that. Thank you.
Right.
Thank you
And
very much.
now I hand it over to Dr. Chinmay to say a vote of thanks. And before that, if he can have some more clarity on few points.
More clarity, yeah.
So it is very late.
Yes, sir. I think everything is clear. Every question has been answered, and all the slides are very good. Good quality of cases, and good presentations. And I thank all the speakers, especially Dr. Dhanasekara Raja, Dr. Dwivedi Bhushan, Dr. Yogesh, our Mukherjee, and Praveen Bharadwaj. So I thank all the speakers, especially Jha sir. Because of you, this is possible. And you are so consistent in taking IORA to such a good height, the height which cannot be reached by any other subcommittee of IOA. I am certain of that. And thank you, Dilip sir. I also thank my teacher and Professor Lahkar sir, who is all along with us, and he's supporting us. So I thank everyone. Manish.
Professor Lahkar has left.
No, he's there.
He is there, sir.
And Mojamdar sir, namaskar.
Yeah.
I am very much, sir.
What is this BHU, this Varanasi program?
It is day before, 2 days back we talk about, and it is certain that we will have meeting at Banarasi in September. Yes.
First week of September, we are having that Banaras conference.
First week of next September, next.
September, sir.
So in between, there will be a seminar, I heard. There will be a seminar, some seminar.
No, sir. We are having a workshop, IORA workshop in Guwahati in March 18. I have given the whole year program in the IORA, our core group.
Very nice. No, you told earlier also, before chopping out.
Yes, sir. Whole year program.
You are very progressive and quite fast.
Right,
Thank
friends.
you, sir.
So now it is time to call it a day. I am so very delighted that this evening I thought it will not extend beyond an hour, but whenever we sit and discuss, we stretch ourselves, and that is good that this subject has been thoroughly discussed. I, on my own behalf, would like to congratulate Dr. Raja and Dr. Yogesh in particular, and all these speakers, because it could be made possible at a very short notice. It was in fact decided on 5th to organize on 11th. And
everyone is alert, sir.
Yogesh, thank you very
much.
Thank you, everyone.
As
All-
concluding remark,
Right.
in
Mr.
one
Chaudhary.
line for our Jha sir, I'll say
Yes.
one line of Rashmi Rati, समझकर द्रोण मन में भक्ति भरिए पितामह की तरह सम्मान करिए.
Very good.
Superb.
Bhushan sir added the cream.
Okay, so we disperse now, and
Yes, sir.
maybe
Okay.
most of us are meeting in IOA at Amritsar. Raja, are you coming there?
Yes, sir, I'm coming, sir. Yes.
Okay, Yogesh is not coming.
No.
Dr. Chinmay is coming,
Yes, sir. Yes.
and Majumdar.
I am in 50-50 chance because I have
50-50.
got some 150-year celebration here.
Oh, okay, okay. So bye. Good night.
Good
All
night.
the
Good
best.
Good night. Thank you.
Good night, sir.
Okay.
Good night,
Thank
sir.
you. Thank you.
Thank you.
Well, all of you, one information will be delighted. I have been awarded to give a lecture in the name of eponymous lecture in the name of Dr. A.K. Saha from Calcutta.
A.K. Saha, yeah.
Yes. So during this IOA.
That, yeah, that
Wonderful.
lecture was
Congratulations.
not-
Congratulations, sir.
Congratulations.
Congratulations, sir.
Okay, thank you. Chalo, badhiya. Okay, all the best.
Okay. Good night. Good night. Bye.
Good night. Good night.
And we thank OrthoTV, IOATV, and
Yes,
all
sir.
the conveners of OrthoTV who always have cooperated with us and have done the miracle of taking the subject right down to the end user. So Dr. Ashok Syam,
Eponymous.
Dr. Neeraj Bijlani, and Dr. Samsul, you
Samsul,
deserve, yes, you deserve all the impetus.
But they are behind the screen. Jha Sahab.
They are always behind, but somebody is there doing it. And I think,
Right.
yes.
Great job. Great.
So somebody is
Great
there on
job.
behalf of Ortho TV here.
Larkar, Dr. Jha.
But Rishi is there, I think.
Eponymous lecture, you know.
Rishi, are you here still? I think he will be closing it in some time. Right. And we should also thank IOA TV, in which the website is functioning and it is there on the website.
And recording also, recording.
Right.
Thank you, sir.
Dr. Jha,
right.
I did not tell you that the Talwarkar's eponymous lecture I gave in Madras conference.
Yes. Must have been long time.
Long ago.
It was long time back. Yes.
That was Talwarkar's eponymous lecture, but A.K. Saha's eponymous lecture was not there.
And now it is there.
Natarajan and yeah, they both were there. Natarajan and this Talwarkar was there. But A.K. Saha was not there. Eponymous A.K. Saha was not there.
Now it is there.
Now it is there. So you are a lucky person because you have met also Professor Saha in Calcutta.
Yes, I have.
That great legend still lives.
Yes, he had turned hemiplegic, but he was assisting in the surgery with his paralyzed hand.
Yeah, whole world knows him. Thank you very much. Thank you.
Good night.
Good night, sir. Good night.
Shantanu.
Yes, sir.
Yeah. अरे Lahkar साहब कब जा रहे हैं? When you are going to Varanasi?
Varanasi, no, sir. Amritsar.
No, Amritsar you are going. Very nice.
Yes.
But on the way back, will you drop at Varanasi to see the progress?
No. Already we are in touch all the time. Jaiswal was in Dibrugarh, and we had a detailed discussion. Some problem is going on regarding.
Achha. Very good. But you did not send a photograph of the mala.
Okay, sir.
You have not sent a photograph of the mala.
Real mala, I will send it to you.
Pardon?
I will give it to you within very short time.
No, you send a photograph. Thank you.
Yes. Already I have.
Thank you. Thank you.
Okay, sir.
Thank you. Thank you. We'll see again. Thank you.
By mourning a tragic loss. Tries to
जय साई राम 9:30 বাজে দেখো আর টাইম নেই গোছাতে হবে না আমি এটা নিয়ে যাবো বলছি তুই মাইকে বলে দিবি তাহলে আর কি মজা এইটা
মা বলেছে না নিতে মাইকে কেন বলবো মাকে বলেছে হচ্ছে এখানে? এই দুষ্টু বাচ্চা। লেট লাগছে আমার। আর আমার কাছে। মা দেখো মা ভালো। ভেঙে গেছে। তুমি না কি করছো?
সেভিং সেটটা পাচ্ছি না তো। আচ্ছা শোনো, আমাকে একটা কিছু চাদর ফাদর দাও না।
আমি ওই চাদরটা পাল্টাম।
এইটা
বলো না।
হ্যাঁ
কোন চাদর? মানে কি দেখাচ্ছো কোনটা দেখি?
আচ্ছা ঠিক আছে, লাগবে না।
মানে ওরে তুমি চাদর পাল্টাম। আমাদের একটা জিনিস পাল্ট করতে হবে।
একদিনের জন্য এত মাল কেন নিচ্ছ? হ্যাঁ হ্যাঁ দিব, কিন্তু ব্যাপারটা কি বলতো, চাদর নিচ্ছ?
কমিয়ে দিচ্ছি সব। এগুলো কেন করছো? এগুলো তো পড়ে যাবো আমি।
না ভর্তি না, রেখে
না কি করছিস? এগুলো তুই সব ছোট করছিস তো? হ্যাঁ করছিস। তোর বিছানায় পরিষ্কার করছিস না। কমিয়ে দিয়ে এখান থেকে দাঁড়া বাবা, তাহলে বুঝতে পারবে। তাহলে হ্যাঁ তোর দুটো জানিয়ে নিয়েছি, হবে তো? হ্যাঁ তোর বেশি কি লাগবে?
আমার একটা,
আমার খালি ঘরে পড়ে চুটি
চান করবো।
নিয়েছি তো, কেন তুমি সকালে চান করে যাবে না? তুমি চান করলে কেউ তোমাকে ফেলেই সবাই চলে যাবে।
না না রাত্রেবেলা।
রাত্রিবেলা চলে এসে তো দুটো নিয়েছি। কেন বোকা বোকা কথা বলিস না? ফ্যামিলি একটা আলাদা জিনিস। এটা তো তোর যে কাপড় সবাই বুড়ো, এখানে কেউ অল্প বয়সী। তোর বাবা তো অশ্ব বুড়ো, বুড়োরও বুড়ো, ঘাটে ঘাটে বয়স, শিং ভেঙে পাঁচুদের দলে যাচ্ছে। আবার হাসছে মিটকে মিটকে। গোপটা কালো করবে না?
কখন দিবা?
আমার এই চুড়িদারটা দিই, এটা তুমি খাবারের বাইরে নিয়ে নাও। মদের বোতলটা এর মধ্যে নিয়ে নাও, ভেঙে যায়। নিচের জামা নেবো তো, ওগুলো ঘাটছো কেন? ওগুলো দলের মধ্যে তোমার মতো কি আমি ওই ঘরের জিনিস করবো?
চাই না তো।
আমি চাইনি, আমি এইটা চাইছি। তোমার জুতো আমার আর দিদি
শোনা বলে না মা।
তোমার না পড়াশোনার ব্যাপারে কেউ তোমার মেন্টাল কন্ডিশন দেখতে আসবে না।